both chlamydia and gonorrhea, and really spent probably a bulk of time discussing mostly gonorrhea with some issues around resistance and treatment challenges. And then Anna's going to kind of come in and discuss more of a public health sort of local epidemiological approach that has had to be pursued, particularly in Washington State in the context of a gonococcal outbreak. So she will be filling in with that. And it's a great honor to have her with us. And for those of you who don't know, what's happened in Washington State has actually achieved national attention. And Anna was actually interviewed on an NPR program a couple of weeks ago. And I include the web link later on in this presentation so you can check it out. But it's not the best way for a state to be gaining recognition nationally, but that is what we have. So with that, I'm going to go ahead and move forward. This is a brief outline. My presentation on chlamydia is going to focus a bit on pelvic inflammatory disease and a little bit of information on screening and epidemiology to date. And then, as I mentioned, the bulk of time I'm going to be spending discussing gonorrhea with a few clinical cases, and we'll move on to talk about treatment resistance and the outbreak itself. So the first case I'm going to present is one that I actually saw. This is a woman I consulted on a few months ago, actually, and it's a really great learning case. So this is a case based on that patient presentation. So this is a 23-year-old woman with a history of fibroids who basically presented with bilateral lower abdominal pain. And when asked to describe the quality of this pain when she presented to her primary care provider, it was sometimes kind of crampy, sometimes kind of sharp, but certainly lower, certainly on both sides. She also endorsed some vaginal spotting. She had vital signs checked with her primary care provider, and they were unremarkable. There were no fevers. There was no tachycardia. He went ahead with a basic lung and heart exam, which was relatively unremarkable. An abdominal palpation exam revealed mild diffuse tenderness, but no rebounds, no masses. A urine pregnancy was negative, and basically she was kind of prescribed rest and reassurance. You know, come back if this grows worse. Let me know if things become in any way complicated. So she went ahead, and I think the clinical thinking at the time was perhaps this was somewhat secondary to maybe the fibroids, or maybe it was an ovarian cystic process. It was a little bit unclear, but sort of, you know, go home and let me know if things get worse. So she went ahead and actually decided to start taking some scheduled ibuprofen and acetaminophen. And about a week later, she ended up in a local urgent care, and I think this had occurred over a weekend. So she wasn't able to follow up with her primary care provider, and she went in saying, you know, I'm having ongoing lower abdominal pain, and this is despite taking the analgesics. She'd had an episode of painful sexual intercourse. And the clinical thinking at this point was perhaps that this was maybe due to a urinary etiology. So maybe pyelonephritis, or maybe it was her passing a kidney stone, just given the sharp, crampy kind of character of what she was explaining. A urinalysis, however, was revealing not for blood, but for leukesterase. A repeat pregnancy test was done at the time, which was negative, and she was sort of given more rest and reassurance. Well, 3 days later, she collapsed from pain at home. She was transported emergently to the local emergency department, and she was actually conscious and was able to give a bit of a history about what had been going on. She was found at that point to be febrile. She was tachycardic. And it was this time that actually a pelvic examination was done by the provider, revealing profound adnexal tenderness, cervical motion tenderness. A CAT scan was done revealing unilateral pelvic enhancement, and the actual appearance of this was a little bit unclear. Regardless, she was then emergently transported to a local hospital and admitted to the obstetrics and gynecology service, who took her to the OR. At that point, it was found that the pelvic mass that had lit up on CT imaging was found to be a large tubo-ovarian abscess. So ultimately, cultures, intraoperative cultures were done, revealing a predominance of some group B strep and some Gardnerella vaginalis en route, by the way, to the hospital where she'd had the surgery. They had hung some antibiotics. I wasn't sure. I couldn't figure out exactly what they were, but she had antibiotics on board. She was switched to different antibiotics after the surgery was done. And it was only after I was consulted representing infectious disease, probably about 3 days later, that I asked for a formal nucleic acid amplification test done for both chlamydia and gonorrhea. And the antibiotic therapy she was on at that point was ampicillin, sulbactam plus doxycycline. So I'm not going to belabor the case too much. I think it probably should be fairly obvious to you all the number of oversights that had occurred and things, the missteps on multiple levels. And so I want to review for you sort of formal recommendations about what to do in the case of acute pelvic inflammatory disease. And this is from the Centers for Disease Control. And it's really recommending empiric treatment for acute PID, or I would say even acute suspected PID, in sexually active young women. So women who are 25 years or younger, or in other women who are greater than 25 that you deem at high risk. And so you would empirically begin treatment if experiencing pelvic or lower abdominal pain. And remember, she kept endorsing abdominal pain. I don't know if the case history would have been different if she had said pelvic pain, but remember that patients have a very challenging time probably noting specifically where the pain is, and she may have even at some point said stomach pain. Regardless, patients are not very reliable in giving an exact location of where their pain is. Practitioners are even less reliable, just basing it on a physical exam and with the history. So it's really challenging to try to determine exactly what that's all about. Also, empirically starting therapy if no other cause can be identified. And so indeed, in this case, no other cause was directly identified. There were some thoughts about what may or may not be going on, but no specific etiology was revealed. And then the final one is if one or more of 3 minimum criteria, including cervical motion tenderness, uterine tenderness, or adnexal tenderness, are present on pelvic examination. And boom, that was the thing that was missed by not one, but 2 different practitioners. So again, young woman, young sexually active woman coming in with abdominal pain, did not have a pelvic examination until her 3rd encounter with a healthcare facility. So what are the potential pathogens that are involved in pelvic inflammatory disease? And this is a very short, brief, abbreviated list. And indeed, while chlamydia and gonorrhea are recognized as the primary etiologic agents that we think of, a lot of data from recent studies have demonstrated that probably fewer than half have one or both of these pathogens, and that in fact pelvic inflammatory disease can be a combination, can be polymicrobial, can involve a lot of anaerobic bugs, Acetobium, Gardnerella, even things like Haemophilus influenza. So we don't necessarily need to be so hung up on the fact that it is necessarily chlamydia or gonorrhea. Regardless, all therapies prescribed for pelvic inflammatory disease will, of course, target both chlamydia and gonorrhea. In the case that I described, I think I made a fairly compelling rationale for why we weren't able to necessarily know if either chlamydia or gonorrhea were implicated as potential pathogens, since I was only able to add NAT testing after she had been on therapy for, I would say, a prolonged period of time. So what if the case had manifested a bit differently? What if early in her course, maybe the first time she presented to her outpatient provider, and her outpatient provider did a full workup including a pelvic examination and suspected mild PID? And what if the patient also reported anaphylaxis to penicillin? So what would be an option for treatment? A, ceftriaxone, doxycycline, and metronidazole, plus or minus metronidazole. B, moxifloxacin. C, metronidazole plus a dose of gentamicin. Or D, none of the above. And we'll go through each of these. I know you don't have an opportunity to necessarily chime in with your votes. It's just something to get you thinking. And A would be particularly bold. In the setting of anaphylaxis to penicillin, I think it would be probably not very wise to go ahead and reach for a cephalosporin. If she had said, oh, I have, rash to penicillin, but I've been on Caplex and I've been okay, or even if she said a more severe reaction to penicillin but had tolerated cephalosporin, you may be okay, but I would not think A is the most reasonable choice. We're going to talk about moxifloxacin in a second. Metronidazole is a great drug to reach for some coverage of anaerobic bugs. Gentamicin would be reasonable. This is kind of a little bit of a data-free zone, so I would probably not go for something that we don't know too much about as far as the most optimal regimen for outpatient care. And we're going to move forward with some of the treatment options. And these are mostly sort of oral options for pelvic inflammatory disease. And as you know, most really are parenteral, at least up front, particularly for women who have severe pelvic inflammatory disease. So more complicated cases. So certainly women who are febrile, maybe they're having some nausea and vomiting, sort of more systemic signs and symptoms. Most of those women ought to be admitted, started at least on IV therapy, parenteral therapy, and then transition to oral therapy as they clinically improve. However, for mild or moderate cases of pelvic inflammatory disease, there are a number of randomized trials that have demonstrated pretty good efficacy between IV and oral options for PID treatment. So that's something to keep in mind for sort of an ambulatory woman clinically doing pretty well, as I can do this, I'll follow up if there are any problems. It would be very reasonable to go there. There is not part of any formal guidelines by the CDC, but a few studies have looked at moxifloxacin, which is, pretty broad spectrum, has pretty good anaerobic coverage. And I only highlight this because it's something that I think we should kind of be paying attention to, and we may, be backed into certain situations like the one I outlined, maybe a woman who doesn't want to be admitted or doesn't need to be admitted, who has anaphylaxis. This may be something to consider. So I'm not going to belabor too much on each specific different treatment regimen that you can easily look up on the CDC STD treatment guidelines. But this is just sort of, to take in mind that there are several oral options. And my only point in this slide is that I think it's often good to make sure that you have anaerobic coverage. There's often the plus minus metronidazole, but I just made a fairly compelling case about women who are very at risk for anaerobic bugs and pathogens. Also not formally part of the CDC recommendation, some data do suggest that parenteral therapy followed by oral azithromycin either as monotherapy or with doxycycline and metronidazole could be an option. So these are just some of the options. The great news about chlamydia treatment is that it really hasn't changed over time. We don't have issues around resistance or treatment failure. It's great. We've got azithromycin, one dose, pretty well tolerated, great for women who are pregnant or not pregnant, or for those who may recommend doxycycline in the non-pregnant patient. We're going to move forward and talk a little bit about the various sites that you want to do testing for genitourinary disease for chlamydia, so the endocervix, which requires a speculum examination. The collection of vaginal swabs, which I think probably a lot of you know that self-collected vaginal swabs are sort of increasingly in vogue, very acceptable, and probably actually reveal better samples than practitioner-collected swabs. Urine samples, very reasonable. A lot of settings practice it because of ease. Rectal swabs, also a lot of data to demonstrate that men do it really well. So particularly high-risk men who have sex with men may do rectal swabs. A question that I often field is regarding pharyngeal chlamydia testing and whether or not we formally pursue that or recommend that, or if that comes from the CDC. And at this point, it does not. I think what ends up happening is the question kind of comes up because most of the nucleic acid amplification tests that people employ in clinical settings are testing for both chlamydia and gonorrhea, which is very reasonable. I think most people are looking for gonococcal pharyngeal disease, and I'll spend a little bit more time talking about that later in the talk, but the pharynx is thought to be a reservoir for gonococcal disease. That particular thinking does not really apply to chlamydia. And I would say that it's exceptionally rare to see chlamydial disease in the pharynx. I would say, I guess, if you happen to find it, go ahead and treat it with a dose of azithromycin. But in general, I wouldn't go hunting for it. This is really what we're classically trained to look for in the setting of chlamydial cervicitis, right? So pus kind of pouring from the cervical os, abundant discharge, friability, edematous ectopy. But in fact, this actually occurs in quite a minority of patients, so probably 10 to 20% of women who have chlamydial cervicitis. And instead, actually, what we really see is demonstrated in the slide just earlier, which is a very pristine-looking cervix. And it is part of what our clinical experience has been over decades, both from the practitioner's perspective and public health guidance, that have demonstrated that, in fact, the majority of women are asymptomatic, have no signs, no symptoms. And so that's really driven what we have now as official screening recommendations. So from the CDC, based on the 2010 guidelines, women 25 years and younger should be screened annually. And then those who are 25 and older that are deemed at increased risk. And there's some categories that you can think of, people with multiple sex partners or have a history of a recent sexually transmitted infection, that kind of thing. But use your clinical discretion on that. As far as counseling and retesting of patients, so in standard fashion, it is to abstain from sexual intercourse for 7 days and until partners are treated, to treat partners if exposed within the last 60 days, and to return if not improved over the next 1 to 2 weeks, basically. The return for repeat testing, and again, this is distinct from test as cure, which is not really formally recommended, but it's to have people come back 3 months after their initial diagnosis and treatment. And it's thought that this is actually the high time for repeat infection. And so this rescreening sort of effort identifies those are at highest risk. It also provides you an opportunity to evaluate partner management strategies. So how well are we doing with screening, in this country? And so again, decades of information have built to try to enhance really, really, really pronounced national guidance on the best, most effective screening for young women who are at risk for pelvic inflammatory disease, at risk for infertility, for tubal factors. So how are we doing in this country? And so the National Survey of Family Growth added a question back in 2006 to the 2006 and 2008 survey that specifically asked about chlamydia testing, and it was a sample of greater than 7,300 women, ages 15 to 44, who were interviewed in person. The response rate was relatively high, and they used some sensitive questioning methodologies to ask and probe for some of these more sensitive questions. And this was presented March of 2012, and what they found was that the chlamydia testing rate for sexually active U.S. women ages 15 to 25 years of age with more than one sex partner in the past year was not 15%, so it wasn't terribly low. It wasn't 26%. It was actually about 38%. So we have quite a ways to go. And it's possible that this was an underrepresentation. It's possible that women may not have known that they were being screened. But even in the setting of perhaps some underreporting, I think we still have a long, long, long way to go in terms of really meeting the enhanced screening needs of young women across the country. So let's spend a little bit of time talking about epidemiology. This is the most commonly reported notifiable condition. The latest incidence estimates for chlamydia is about 2.8 million cases annually, with the prevalence reaching almost 7% among girls 14 to 19 years of age. And this slide probably you've seen before if you've ever seen any kind of overview on chlamydia. And so, women have in general had more infections than men, and that is perhaps part of the screening strategies. We've seen an ongoing elevation and a rise over time from the 1990s. And this probably reflects a combination of different things, probably, again, orchestrated some successful screening efforts, probably also the advent of better testing technologies, including NAT testing. But I do think we're actually also seeing a higher number of cases over time. This one I always find rather humbling, and that is sort of showing the failure that we have in reaching some of our harder to reach, more marginalized populations. Black African Americans across the country continue to be disproportionately affected, both by chlamydia and gonorrhea. I feel like you could almost represent this slide for any number of different sexually transmitted infections. The other category of individuals that are impacted quite heavily by chlamydia are American Indians and Alaska Natives. I know we have a number of individuals from Alaska on this webinar, so thank you for joining us. We have a lot to learn about how best to really outreach to these very, very challenging communities. It's interesting also, this is something that the CDC and a lot of local state departments are actually capturing, and that is where are individuals going for their STD care. And this is a percentage of reported cases of chlamydia by sex and selected reporting sources back in 2011. It's kind of interesting. Women in general tend to go more often than men to any number of different settings. They're likely to go to private physicians or an HMO, and followed by maybe family planning clinic, something like a Planned Parenthood, I would guess, or maybe another health department affiliated clinic. Fewer numbers go to STD clinics. Emergency rooms are also hovering at about 5%. Men also go to private physicians, but they also, in pretty robust numbers, actually visit the STD clinics for basically their STD care, and specifically also for chlamydia. So let's move forward and talk a bit about gonorrhea. So I have a couple of different cases. This is a 25-year-old man who has sex with men who presents for an STD check. He endorses both receptive oral and anal sex. He had syphilis about 3 years ago and was tested for HIV 3 months ago and was negative. He has 3 to 4 semi-regular sex partners. His urethral sample tests positive for gonorrhea, but you don't carry ceftriaxone. What do you offer? So this is a pretty typical case, I'm going to say. This is very, very, very common. So would you A, send culture and give 2 grams of azithromycin and pursue a test of cure? B, send culture and give cefixime plus azithromycin and a test of cure? C, send this person somewhere else and refer to a location that does offer intramuscular therapy. So we're going to return to this case after we review a little bit about the topic. So let's start out by discussing sort of screening and testing the same way that we did for chlamydia. And really, diagnostics on gonorrhea have come a little bit full circle. And so although we continue to rely heavily and very appropriately on nucleic acid amplification testing, culture ends up being, at this point, our most optimal way for us to follow the important things that we're going to be talking about, which includes drug resistance. Now, I understand many of your settings, probably you don't do culture. I'm just saying that it's handy in a number of different settings. It may not necessarily be completely relevant for your settings, depending on the patient populations you have that are coming to visit you in your clinic. But from a perspective, we do have culture in the STD clinic, for example, in King County in Seattle. So the Grant stain also continues to be great, high sensitivity and specificity on male urethral specimens. If you see gram-negative diplococcygenes PMNs, then you've made your diagnosis. So the thing that cultures offer that currently NAPs do not is an ability to test antibiotic susceptibility. And so while not nearly as sensitive as our molecular methods, we're going to talk a little bit about why it's become more important in a variety of settings. So What are the targets for testing for gonorrhea? So mucosal targets, urethral, cervicovaginal, oropharyngeal, rectal, and conjunctival. For men, urethral gonorrhea is almost always symptomatic, so it's often sort of a visible purulent discharge. And very, very similar, unfortunately, to chlamydia, is that the vast majority of women who have gonococcal infection are actually not symptomatic. So upwards of 80% of women don't have any symptoms of gonorrhea. Going back to men, upwards of 1/3 of urethral cases occur concurrently with pharyngeal infection among men who have sex with men. And the majority of gonococcal infections among men who have sex with men actually occur in extragenital sites, so either the pharynx or the rectum. And those infections actually tend to be asymptomatic. So again, NAT testing, most sensitive, FDA cleared for the widest variety of specimen types. I've listed a few of the different NATs available. As far as extragenital samples, labs need to obtain sort of additional validation to test for those sites. And again, the limitation for NAT is drug resistance testing so far. That may be changing over time as technologies improve. Moving on to screening, this is for all sexually active women younger than 25 should undergo annual screening. Pregnant women should be screened in the first trimester, and then routine screening is also recommended for women older than 25 years of age who are at high risk. Again, those with multiple partners, previous history of STD, and any number of different things that you find to render them at high risk. As far as screening for men, it really recommends screening, the CDC recommends screening for sexually active gay, bisexual, and other groups of men who have sex with men, testing for both chlamydia and gonorrhea of the rectum if engaging in receptive anal intercourse in the past year, urethral chlamydia and gonorrhea if engaging in sort of anal or oral sex in the past year, and then pharyngeal gonorrhea if engaging in receptive oral sex in the past year. I'm going to switch gears for a second, and you'll see a little bit more about this later in the talk when Anna talks about what's happening more locally in the Spokane area. But I want to talk about methamphetamine use. And for those of you who are practitioners who have seen individuals who are, for example, HIV positive or other groups of men who have sex with men, or in general people who are more likely to be using illicit substances, you know, there's strong associations with meth use, both with HIV and syphilis, particularly among men who have sex with men. And until recently, we didn't know a whole lot about what it meant specifically for women. But Pamina Gorbach and colleagues at UCLA endeavored to learn the impact of meth among women in a cross-sectional study of women attending publicly funded sexually transmitted clinics in Los Angeles, California. So they sort of looked at routinely collected data to compare the prevalence of meth among women and looked at sort of different demographics and sexual behaviors. And then they ended up doing a logistic regression to identify predictors of meth use. So what did they find? And what they did find was about 1.4% of those women, among the 277 women in these local STD clinics, reported meth use with a mean age of about 29. The prevalence was highest among whites and those reporting both male and female partners. And then when you kind of do a multivariable analysis, so controlling for age, race, ethnicity, condom use, and having a new sex partner, and other illicit substance use, women who reported sex with an injection drug user were nearly 10 times more likely to report meth use as compared with those who did not, with an adjusted odds ratio of 9.9. So other factors associated with meth use included sex with a recently incarcerated partner, anonymous partnerships, transactional sex, and ultimately women who tested positive for chlamydia or gonorrhea were 1.48 times more likely to use meth as compared with those who did not. So, you know, part of this is they're not very shocking results by any stretch of the imagination, but just more and more evidence that sort of there is this ongoing connection between illicit substances and high-risk sexual encounters. We're going to switch gears again. This is, I don't know the date of this particular photograph, but as you can see, the sign says, penicillin cures gonorrhea in 4 hours. my favorite part of the talk. This is a talk about treatment of gonorrhea. And I want to give you a little bit of a historical context. It's very interesting going back into the history textbooks to learn about sort of the advent and the introduction of gonorrhea in sort of the Western Hemisphere anyway. And so though the gonococcus was formally identified in 1879 by Neisser, our history texts date back several hundred years prior to really document infected individuals and a whole host of incredibly unsuccessful and very painful sounding therapeutic efforts. So there were a variety of salves, ointments, metals that were rubbed on likely herpetic and syphilitic lesions, and then other compounds were concentrated into liquid form and injected via intraurethral installations into these poor chaps who had purulent urethral discharge. At this point, I imagine all the men in the audience that are listening to this webinar have now crossed their legs. So mercury on the Mary Rose warship was found, and there were syringes, and these intraurethral syringes with mercury concentrations, silver nitrate. This was back in the 1500s. There was the gonococcal vaccine, which lasted about a minute back in 1909. Failed, obviously. Arsenic, bismuth, gold. And then there was my favorite, which is heat therapy, which is depicted in some incredibly vivid paintings showing some poor, suffering men having their pelvic compartments descended into heat chambers. Literally, open flames, fires outside of these chambers. And so I think the thinking was that high heat, high levels of heat were destroying the gonorrhea. You can imagine it also destroyed their sex drives forever. But needless to say, things were not going so well for the best therapy for gonorrhea for a prolonged period of time in our history. So I'm going to outline a little bit of where we've been as far as antimicrobial resistance. And this is a slide that I'm borrowing from Kim Workowski. She's the lead author on the CDC's STD treatment guidelines. And I'm going to go step by step. So back in the 1930s, sulfonamides were introduced, 1936, and were effective for about maybe a decade. And so by the late 1940s, sulfur resistance was pretty widespread. Next, penicillin, 1945. Impressively enough, though, even by the late 1940s, there was some evidence of chromosomal-mediated penicillin resistance. In the late 1940s, tetracycline was introduced, and again, over the next decade, maybe 2 decades, more widespread, both chromosomal penicillin-mediated and tetracycline resistance, documented gradual increases in minimum inhibitory concentration. So really, really documented lab needs for increased amounts of drug to penetrate these bugs. By 1976 was the penicillinase producing N. gonorrhea, and that was documented in a laboratory. And 1984, plasmid-mediated tetracycline resistance was isolated. So what we're seeing is overall ongoing impressive evolution of different kinds of resistance over time in relatively short time frames, I would argue. It was in 1989 that ceftriaxone was recommended as the primary therapy for the treatment of gonorrhea, and penicillin was formally dropped. It was back in the mid to late 1980s that quinolones started to be used for gonorrhea. And remember, the quinolones, when they first kind of came out, were used for everything. There was just widespread use because they covered for so many different organisms. So the use of quinolones in general was pretty widespread. But the first case of quinolone-resistant Neisseria gonorrhea was actually detected in Hawaii back in 1991. Cefixime actually entered into the scene as an oral cephalosporin back in 1993. And because of the rise in cases of quinolone-resistant gonorrhea, which was thought to come out of Asia, hit Hawaii, and then march up the west coast of the United States, and formally in 2007, quinolones were no longer recommended, and we were left basically with cephalosporin as the only documented best therapy for gonorrhea. So where did we go from there, and where are we now? So ceftriaxone treatment failure was first identified in 2011 with a report of a pharyngeal gonococcal case in a female sex worker back in Japan. This was H041, and had a ceftriaxone MIC of 2 micrograms per milliliter. And this acquires the title of superbug. And I'm sure you all saw lots of magazines and sort of TV reports about this, due to its high-level resistance both to the ceftriaxone but also to cefixime, penicillin, and levofloxacin. And it was thereafter that subsequently we noted ceftriaxone treatment failures also in Sweden, Slovenia, France, and Spain. The 3 primary resistance mechanisms that we know of that make gonococcus sort of as wily and as evasive as it is result in decreased susceptibility to beta-lactams with the PEN-A, MTRR, and PEN-B modalities. So PEN-A, as a review, it basically encodes a change in penicillin binding protein. MTRR causes an overexpression of an efflux pump. And then PEN-B sort of alters the outer membrane porin. So one potential explanation, for those of you that are kind of interested in the pharmacology and resistance, one potential explanation for the greater prevalence of cefixime resistance over ceftriaxone resistance among gonococcal specimens is that although nearly all cefixime resistance is due to the mosaic PEN-A allele, ceftriaxone actually requires PEN-A, MTRR, and PEN-B mutations to result in clinically significant resistance. So needless to say, the reports that came out of Japan and some parts of Europe really led to changes over time. More and more attention. The medical literature is just swimming with more and more evidence about sort of increasing evidence of alert MIC values in different settings. The graph on the left shows in red the cefixime with isolates that exhibit alert value MICs over time. So between 2009, 2010, and 2011, you can see sort of levels of escalation of alert values. The blue is ceftriaxone, and so those sort of are slowly also kind of marching forward and up. Azithromycin is just being documented and known. The graph on the right shows proportion of isolates with resistance in general, and these are for the blue is doxycycline and the yellow is ciprofloxacin. And so overall, you can see that there's more and more of this information is being followed quite closely. So, the proportion of isolates tested by the Gonococcal Isolate Surveillance Project, which is out of the CDC, of these drugs between 2006 and 2011 are showing greater levels of sort of resistance across time. Alert values of MICs for cefixime are 0.25 micrograms, 0.125 for ceftriaxone, and for azithro it's 2. So, not that these are things that you need to necessarily, the numbers don't mean that much, but just recognizing the overall trends in terms of your own clinical practices. So the primary source for surveillance of resistance for gonorrhea is what I just mentioned, the Gonococcal Isolate Surveillance Project, which is a collaboration of 28 sentinel clinical sites and 5 regional laboratories that are funded by the CDC. It was started back in 1986 to really help provide a base for the selection of gonococcal treatment. And so this is just a depiction of where they are across the country. So again, this depiction is actually helpful to try to understand, where are we seeing the greatest resistance, and what populations have exhibited, or what specimens from what populations are showing the greatest resistance. And this is isolated MICs for cefixime. So again, greater than 0.25 micrograms over 2005 and 2011. And you can see with the red hashed line that the majority of those isolates are actually recovered from men who have sex with men. And then the line below it is actually those on the West Coast. So, and not to say that there is not resistance in other populations, as you can see below on the Midwest, men who have sex exclusively with women, and then those isolates in the Northeast and the South. But you can see a pretty dramatic trajectory for MSM, for men-who have sex with men, and for individuals who are residing on the West Coast. So let's go back to that case. If your urethral sample says positive for gonorrhea, you don't carry Ceftriaxone. And so what you offer is it's 2 grams of azithro, and you obtain a culture and you pursue a test of cure, or do you send a culture, give cefixime plus azithro and a test of cure? Refer to a location that does offer IM therapy. And so we're just going to jump to the most optimal therapy, which is the ceftriaxone plus azithro, which is preferred over doxycycline, basically because of what I had shared with you regarding tetracycline resistance over time, seeing more and more of that ongoing. And just to step back for 1 second, is that this is regardless of chlamydia test results. So remember that we have historically used 2 drugs, with the second being for co-treatment of chlamydia. And that thinking is actually quite outdated now. And so instead we're relying on a second agent because we have a pathogen that is quite capable of very evolved mechanisms of resistance and demonstrated resistance globally. So in the same way that we know that 1 drug, or even 2 drugs at this point, cannot be used to treat tuberculosis, we now have 2 drugs that we need to be as aggressive as possible against gonorrhea. So that's the thinking there. As far as alternative therapy, so this would be if you didn't have the option of IM ceftriaxone because you're in a clinical setting that doesn't offer it, doesn't carry it in your pharmacy or in your clinic. The other option is to do cefixime orally, 400 milligrams times 1 plus azithro. Again, preferred azithro over doxycycline because of resistance. And the CDC is, at this point, still continuing to say sort of test of cure with NAT is recommended 7 days later if you're using an alternative regimen. And I would just say that that's particularly true if you're trying to treat pharyngeal gonococcal disease. But in reality, although this is an alternative therapy, oral therapy, oral cephalosporin therapy is generally thought to be less favored for gonococcal pharyngeal disease. And so that's why the ceftriaxone would be the best thing that you could possibly reach for. However, the combination of oral cephalosporin plus azithromycin is pretty effective. So that's what you would reach for if you didn't have it. The other twist in the case, I think I had mentioned 2 grams of azithromycin, and that's something to consider if somebody actually has a sort of a severe penicillin allergy. So that would be a consideration. And again, I would certainly the CDC recommends a test of cure if possible 7 days, and in some settings it's later than that. So official recommendation 7 days post-treatment. Local guidelines may differ on this. It may be 7 to 10 days or 7 to 14 days. I think either is fine. The national guidance on this is still evolving. It clearly has a lot to do with sort of local resources. As far as retesting recommendations, it really ought to have, both for chlamydia and gonorrhea, folks should be retested 3 months later, and really pretty much at any point that you have an opportunity in the next 1 to 12 months post-therapy. So what do we have as far as options for the future? We have a couple of different antibiotic regimens using what we have are existing drugs, and this is a big CDC and NIH trial, so injectable gentamicin with oral azithromycin, or oral gemifloxacin in combination with oral azithromycin, so pretty good effectiveness in curing genital infections. Both combinations cured 100% of the infections of the throat and rectum as well. The only novel option that is really about to enter clinical trials, I think perhaps has, is a fluoroketalide. It's a form of macrolide. It's called solithromycin. There's pretty good in vitro data that supports this as effective both against gonorrhea, including against cephalosporin-resistant gonorrhea, as well as against chlamydia. So I'm going to be wrapping up shortly. This is a 19-year-old MSM with 2 regular sex partners who test positive for pharyngeal gonorrhea. You treat them in your office with the appropriate therapy, IM ceftriaxone plus azithro. And so A, Do you offer Cefixime plus Azithro as patient-delivered partner therapy? B, offer Cefixime plus doxycycline as patient-delivered partner therapy? Or C, do you not offer patient-delivered partner therapy? And this is a little bit of a trick question, and this is at this point currently a challenging situation. Is that while we do know that patient-delivered partner therapy is really a great management option. It's actually not recommended at this point for MSM communities. And that primarily has to do with really the desire and the need to have high-risk MSM kind of engage in healthcare. So really to come in, not only to be tested for gonorrhea and chlamydia, but come in, be tested for syphilis, be tested for HIV. And so that's part of the response in this question. So in reality, patient-delivered partner therapy is terrific, but at this point in time is really dedicated to heterosexual populations, and the best answer for this would be to go ahead and do Cefixime plus azithromycin. Again, azithromycin favored over doxycycline, and very effective, a very, very reasonable option if you can't get a partner in to be tested and treated with IM ceftriaxone. So, as far as patient referral, ask them to notify the partner, ensure treatment, have the patient bring the partner into clinic, and really sort of do whatever you can to expedite therapy. There's, of course, the provider or clinic-based referral, health department referrals as options. Just a few words about epidemiology. This is, as of 2011, gonorrhea was the second most commonly reported notifiable infection in the United States, with about documented 321,000 cases reported, but probably the true disease burden may be closer to 800,000. This is a depiction of sort of, where we were over time, and as you can see, sort of in the 1970s, rates were pretty high over time. There was a sort of steady decline over the next decade or two, and then what we've seen over time between 2006 onwards, and certainly since 2010, is a bit of an upswing. It's kind of interesting, again, sort of the disproportionate character of gonorrhea affecting really in pronounced fashion, again, African Americans in this country, with rates, catastrophically higher than other populations. Again, American Indians and Alaska Natives. So just interesting to note that, and a reminder of how far we need to go. Incidence varies substantially by geography, with the highest rates in the United States found in the southeastern states. Again, this is also true of chlamydia. And then among the network of 12 Sentinel STD surveillance sites, the distribution of gonococcal infections by gender and sexual orientation was actually about 22% MSM, 31% heterosexual men, and 47% women. So, there's a wide geographic variability about what we're seeing in classic fashion across the country. Aggregate numbers, its highest concentration is really in young women, those that are 15 to 19, and then also those that are 20 to 24 years of age. But again, the story is very different depending on where you live, whether you're in a big urban setting on the West Coast or in the middle of the country. So the stories can be quite different. So, and to that tune, I'm actually going to hand it over to Anna, who's going to share a little bit of what she's seen in Washington State and specifically in Spokane.
Thank you, Dr. Singh. Fabulous presentation. Hello, everyone. My name is Anna. I work for the County Health Department in Spokane, Washington. We're in Eastern Washington. And I realize that a lot of you are outside of Washington State, and in fact, we'll be focusing on one particular county here. But our intention is to highlight some of the challenges related to outreach and disease management and surveillance during an outbreak. So I hope that you find this interesting. I don't know what happened to my little background here, so this isn't as pretty as it was before. I apologize. So what's the definition of an outbreak? It's a 50% increase or greater in a quarter compared to the average number of cases in the previous 6 quarters. Washington State, all over the state, we're having a bit of an increase, and as of the end of September 2013, 5 of our counties have declared outbreak status. Spokane is in the eastern part of the state. Yakima and Benton are essentially in the central part of the state, and Kitsap and Thurston are on the west side of the state. And I'll be focusing this talk on Spokane. Spokane is a mid-size county in Washington. We have about 480,000 total population. We're on the opposite side of the state from Seattle. And thankfully, we're not talking huge numbers of gonorrhea that we're experiencing. You can kind of see our total reported cases as of the end of October. Washington State's rate is still significantly below the national rate. In 2012, our rate was less than 50 per 100,000 population. Nationally, in 2011, it was just over 100. It was 104. So we're really not talking enormous numbers like we're experiencing in the South and parts of the East or in Alaska, but our rates are increasing, and that's concerning to us. Washington State overall has experienced an increase of 33% over the same period last year. By comparison, chlamydia is showing no year-to-date change, so we're really experiencing a problem with gonorrhea right now. And we don't really know definitively yet why we're experiencing an increase. Washington State in and of itself has been experiencing an increase since 2009. We don't believe that our increases are related to any sort of treatment failure. And in looking at this slide now, I'm a little bit worried that I was misleading. I don't know that our outbreak is related to meth use or if it's related only in racial and ethnic minorities. I just wanted to include these two things as things to note. Racial and ethnic minorities continue to be disproportionately affected. That's true pretty much anywhere. And meth use has been reported in about 25% of our interviewed cases that were asked about meth use. So that's self-reported, and like Dr. Singh was talking earlier, illicit drug use is associated with a lot of high-risk sexual encounters. And if gonorrhea is infiltrating these sexual networks, it really makes sense. We don't have good historical data to compare to at this point, but we are concerned about the self-reported meth use this year. A few graphs I'll go over briefly. You can see here that we've experienced some sharp increases in the mid part of the last decade that then dropped off. And you can see here where I talked about the increase that we've been experiencing since 2009. We have some theories about why this increase might be happening. It might be better screening, more providers might be screening, better testing technologies are being used, better reporting, or are there just more cases? It's probably a little bit of everything. This slide represents the reported cases by sex and quarter. You can see our increases happening just over the last 12 to 18 months here. You really don't see this with chlamydia. More women are screened and therefore diagnosed, so you see a lot more women getting diagnosed with chlamydia than men. This, to me, reflects more men getting tested because they are symptomatic, which Dr. Singh talked about a little bit earlier. Most gonorrhea cases in men are symptomatic, so they'll often seek treatment for that. This slide just kind of depicts our gonorrhea cases by sex and sexual behavior. So in Spokane County, our outbreak is not related to, it's not in our MSM population, in our men who have sex with men. Men who have sex with men represent about 15% of our gonorrhea cases, so still pretty high considering that MSM are a minority population. In King County, which is Seattle, the increase this year is mostly in MSM, but this depicts what's happening locally. Syphilis locally and across the state is nearly all MSM, but our current outbreak is in our heterosexual population. This kind of goes over age groups. Of note here is that the age group of 25 to 29 is most affected in terms of sheer numbers. With chlamydia, you usually see those 15 to 19 and 20 to 24 age groups more affected. These higher rates in women here probably depict better, more screening in those populations. This slide depicts where our cases are being diagnosed. Of note, our urgent care and hospital ER centers are diagnosing the vast majority of our cases, probably because a lot of men are seeking treatment once they're becoming symptomatic, but also missed opportunities for screening. We're also seeing a lot in our correctional facilities. And we're doing great in using first-line treatments also. You can see an increase over the last several years in the use of ceftriaxone, which is really great. Our providers are doing a great job. So what are we doing? We're continuing to interview all reported gonorrhea cases to assist with partner notification and treatment. We encourage the use of expedited partner therapy, and we educate our providers around treatment guidelines to ensure that ceftriaxone is used whenever possible, in addition to the azithromycin and doxy. We've issued some press releases and done some provider letters, and we've done a lot of media around gonorrhea, and that was picked up we got some national attention, as Dr. Singh mentioned. Trying to encourage testing. We're doing some limited testing in our needle exchange to ensure access to services in populations that may not be receiving those services elsewhere. We have no STD clinic in Spokane, so we're really trying to do what we can to get people tested when they need it, and continued surveillance. I'm going to wrap things up since we're a minute over time now, but if you have any questions, please either direct them to my email address or type them into the chat box there to your left.
Great. Thank you so much. Due to the fact that it is just past 1 and we are to end at 1, we are not going to be able to take live questions right now, but we did see a couple come in the chat box that we will direct to the faculty, and we will try to get in touch with you to answer those. If you have further questions, you can email the faculty members on this call or the Seattle Training Center at seaptc@uw.edu. Please stay logged in order to be redirected to the website for continuing education.